All right, we're going to go ahead and get started. I gave people a few minutes to get in. So just a few announcements before I introduce Dr. Fernandez-Becker. Our next GCP workshops are in August 11th and 18th. They are the same classes. Don't sign up for both of them if you're interested. But the topics will be 13 Principles of Good Clinical Practice and Keys to Recruiting, Consenting, and Enrolling Study Subjects. And those will be with Patty Casper, like the previous workshops were. The next brown bag is June 16th in MSOB June 16th, so 2 weeks from now. And then our next science series in July, the date is to be determined as well as the topic, but I'm trying to narrow in on the topic. I think it's going to be on heart failure. Okay, so Dr. Nielsen Fernandez-Becker is our speaker today. She joined the School of Medicine at Stanford in 2009. She is a clinical assistant professor in the Department of Medicine in the Division of Gastroenterology and Hepatology. She's the current director of the Stanford Celiac Management Clinic, where she is highly experienced in diagnosing and managing the treatment of celiac disease and other gluten-associated disorders. Her other areas of interest include allergic GI disease, including eosinophilic esophagitis and food allergies. So please help me in welcoming her to our lecture today. And we really appreciate you being here and educating us on GI. Oh, what did I do? I don't know. We'll see if it comes back. And if you can put this on, because we're going to record. And let's see.
So I guess I can't move it.
No, I don't have a clicker.
Okay.
I can stand here and be your person.
Oh, that's probably why.
Yes.
Okay.
Do you want to shift it like this? Yeah. Yeah, that will be.
Okay, so good afternoon, everyone. So I was asked to speak about GI physiology and pathophysiology, which is an immense subject. So we really are going to cover a lot. So we're not going to go into minute detail, but if there's interest and there's time later on, we could delve into any of these things in much greater detail. But this was intended to give you more of an overview. Great. So the anatomy of the GI tract. So just to clarify, I will be talking today about the GI tract. The digestive system includes other extraintestinal organs such as the liver and the pancreas, and we'll touch upon those. But really what we're going to talk about today is what we consider the GI tract, which is the luminal GI tract, the esophagus, the stomach, the small intestine, and the colon, or the colon includes also the rectum. So what are the functions of the GI tract? And very broadly, when we think about GI, we think about digestion, we think about absorption of nutrients. Also, a lot of people don't realize it, but the GI tract is actually our biggest immune organ. But also, motility is really important because, and the other area that I focus on in clinic is GI motility, which is how do you propel the food and the waste out of the body. So we're going to go from the top to the bottom. We're going to start with the esophagus. And initially, I was going to do this as just talking all about the physiology and then doing all the pathophysiology, but it made more sense to talk about the physiology of the segment and then talk immediately about the pathophysiology. So that's what we did. Feel free to stop me if I'm using too much jargon, just tell me. Okay, so this is the esophagus. And the esophagus really is a long tube. And its function really is to get a conduit to move food from the mouth into the stomach. And so it's usually about 20 to 22 centimeters in length. It's variable, and how long it is can correlate to how tall the person is. And it's made up of different types of muscle. So it's a muscular hollow tube. The upper 5% is striated muscle, and what striated muscle is more like under voluntary control. So it's more like skeletal muscle, like our hands. The middle third is a combination of both smooth muscle and striated muscle. Now, smooth muscle, which accounts for the lower bottom of the esophagus, is more automatic. So it's like heart muscle. And the esophagus has two high pressure zones, and that's the sphincter, the upper esophageal sphincter. That's what opens to allow food into the esophagus. And then you have the lower esophageal sphincter. And the lower esophageal sphincter is what keeps food, what keeps the contents of the esophagus, of the stomach, from coming back up into the esophagus. And we'll talk about that a little longer because it's involved in some pathogenesis. Okay, so when we think about esophagus, swallowing is where everything starts. And I know this is technical, but the bottom line is that there's several different phases when we swallow. There's and this requires coordination with the brain, because even here it says the oral preparation stage, so even before that, the contemplative stage, when you're thinking about eating, things are already getting activated in the brain and sending signals to our GI tract to get things started. So the mouth is where things start. The preoral stage is chewing of the food to make it a little easier for us to swallow. Then there's the oral stage, which is basically the tongue propelling the food bolus to the back of the throat, what we call the pharynx. And the pharyngeal stage is basically when, so the esophagus is right in front of the windpipe, the trachea. So this swallowing is actually incredibly complicated, because what needs to happen is for the windpipe to close, and the upper esophageal sphincter that I showed you before has to open. And all of this has to be coordinated so that food doesn't go down the wrong way. And when the person has had a stroke and these muscles are not working right, then that's a possibility. So then what I'm more concerned about is so when we talk about these things, it's really not in the realm of gastroenterology. And whenever we have a pharyngeal problem, that's more ENT helps us out. But the esophageal stage is once food hits the esophagus, what's the process that propels it down into the stomach is more of what we take care of. So this is going to be really complicated, but the whole, again, this whole swallowing thing is extremely complicated. A lot of coordination. It requires different parts of the brain. It also requires, so the brain has, the GI tract has its own nervous system. It's called the enteric nervous system, second only to the brain in number of neurons. So you've probably heard out there that the GI tract has its own brain. It's true. And for swallowing and for all the GI function, it's a coordination between the CNS and the ENS, the enteric nervous system. And so striated muscles, like I told you, that's more skeletal. CNS means central nervous system, so this is the brain. So the brain controls some aspect of this, but also the enteric nervous system is the nervous system of the intestines also controls it, and it controls mainly the more smooth muscle function. And there's different chemicals that are important here, like these abbreviations. NO stands for nitric oxide, and ACH is acetylcholine. So timing of peristalsis, and we're going to talk about what peristalsis is, but the bottom line is that it requires both contraction and relaxation. And nitric oxide is what relaxes, and acetylcholine is what makes it contract. And this is peristalsis. So basically what peristalsis is very coordinated sequential contractions. So to push the food bolus down. So you're going to need contraction above, relaxation at the bottom. And then when you get to the next part, the same thing happens. So one of my patients once told me it's like milking a cow, right? So if you do it all at once, nothing's going to happen, but you have to do it sequentially. Same thing with the esophagus. So you would have contraction here, relaxation down here, and then the cycle repeats. So remember that acetylcholine that's made by some of the nerves in the stomach is the force that causes the contraction, and nitric oxide is the force that causes the relaxation. And all of this has to be in coordination. And the idea is, so these waves of muscular contraction then propel the food bolus into the stomach. And this is part of the reason why I couldn't send the actual presentation last night, is because I took all these pictures from our own files. And this is what I look at. So the best way to look, yeah?
So I have a question. So when peristalsis is happening, is there like a timing? Like, so what is that duration? Because I know some people eat fast, some people eat slow. Clearly our body adapts itself to it.
Yeah. So I think there's no one like normal range. I think everybody's different. It's more about timing of how long it contracts and how long it relaxes. But eating fast, not the greatest thing in the world. I had to come in 2 times last week to remove food from somebody's esophagus. And that is a product of eating too fast and not chewing fast enough. Not chewing enough. So if you have huge chunks, it could literally get stuck at the esophagus, particularly if there's dysfunction, I mean. Okay, so this is the esophagus. And what we do is we have an endoscope, which is a fiber optic camera. It's flexible. We're able to pass it under direct visualization into the esophagus, then into the stomach, and then into the small intestine. And what it looks like is a tube. So you may not be able to see it well here, but normally we see blood vessels. We see a very smooth surface. The lining of the esophagus is more of what we call squamous. So it's like our skin. But then at the bottom, you may not appreciate this much, but I'm going to try to convince you that this is a different color than this. And the paler color is the squamous mucosa, whereas the stomach mucosa, or mucosa just means the lining, is a little different because it's glandular. And one of the functions of the esophagus, of the stomach, is to make hydrochloric acid. So the stomach can withstand that. So whenever we want to study the esophagus, endoscopy gives you direct visualization. Sometimes we're interested to see if there's a scar tissue or narrowing, depending on what the issue is. And then we have patients swallow barium, and they take x-rays. They kind of do this live, so we could see how well the stomach is moving and to see if there's any mechanical obstruction. So what you normally see is pretty much a thin tube. It has a little tapering at the bottom. That's where the lower esophageal sphincter is. And then with time, you see it kind of strip down into the stomach. We also have other ways of measuring the amplitude of the contraction, as you asked, how long and how fast, and how intense the contraction is. And what we have is something called esophageal manometry. This is a very small tube. It's probably about half of the diameter of my pinky, and it has sensors for pressure. And what it allows us to do is to see how intense the contraction is and how long it's taking for a food bolus to go through. So what we do is we give patients sips of water, and then we measure this. And the information, so this is the pressure information that you would see here, gets coded by some really complex organism, or algorithm, not organism, and coded in color. So the warmer colors are the higher pressures, and here's the scale, and the cooler colors are the lower pressures. So I'm going to explain what this is to you guys right now. So 2 high pressure zones, right? Because we know it's high, very warm colors. The upper esophageal sphincter and the lower esophageal sphincter. And then this is the esophageal body, so this is sequential contractions. So what you should see is a very nice diagonal, normally. And the reason I'm showing you this is because I'm going to show you some pathophysiology while this is all messed up. So normally when you swallow, what happens is that the upper esophageal sphincter relaxes. That's why it goes from red to blue. And then the pharynx contracts. And that's why you see the spike here. And then remember how I told you that the first 5% of the esophagus is striated muscle and the rest is smooth muscle? So this is why you see a little bit of an interruption there. And then most of this is smooth muscle, and eventually, so the other thing that happens when the upper esophageal sphincter relaxes is that the lower esophageal sphincter relaxes, because you want the hose to be open on the other end. And there's diseases that affect these processes. We also sometimes are interested, acid reflux, heartburn is a very common complaint, so we have tools to actually measure whether acid is making it up into the esophagus. And again, this requires a catheter to be placed into the stomach and then pulled back so it's about 5 centimeters above the lower esophageal sphincter. And what this is a sensor for acid. There's also a wireless version, but it's the same concept. Now, so that's my little bit of physiology. Now, let's talk about pathophysiology. And I thought we could talk about gastroesophageal reflux disease because it's very common. Also dysphagia, this difficulty swallowing, as well as some inflammation and more along the lines of this, what I do. Okay, so what is gastroesophageal reflux? So gastroesophageal reflux is basically the contents of the esophagus come up into the, of the stomach comes up into the esophagus. And why could that be a problem? Well, if you remember, the esophagus is more like our skin. The stomach makes hydrochloric acid, so repetitive reflux can cause almost like caustic damage to the lower esophagus, and that could cause some changes over time that could be problematic. And not to mention symptoms. It can cause a lot of symptoms. So what you have here is the esophagus, and one thing that I forgot to mention to you is that what separates the chest cavity where the esophagus is and the stomach, which is more where the abdominal cavity is the diaphragm. It's a very strong muscle, and it contributes to the tension of the lower esophageal sphincter to prevent things from refluxing back into the esophagus. Now, in order for the esophagus to connect to the stomach, there's a little defect in the diaphragm that happens in embryogenesis. But sometimes there's problems here, and this gap becomes wider, and that's one of the reasons why people develop reflux. So once food gets into the stomach, and we'll talk a little bit more about it, it gets churned in there. So this should be closed, otherwise we'll have problems. And there's several different mechanisms by which the lower esophageal sphincter could remain open or open inappropriately, causing reflux. And this is what this cartoon, I found all of these great cartoons online, and I thought they were helpful. But there's a ton of things that can lead to reflux. One is, so impaired esophageal clearance means that the esophagus doesn't contract normally. So there's going to be less resistance for the liquid to go back. And impaired salivary function, impaired mucosal defense, same type of concept that lubrication is a problem, and we kind of lose the defenses. Some patients have low pressure at the lower esophageal sphincter. That could be because of disease. That could be sometimes for reasons that we don't understand. If a patient has delayed gastric emptying and things are not going out of the stomach, then that could cause enough pressure to push things back. Also, too much acid in the esophagus can cause problems, in the stomach cause problems. One of the most common mechanisms is something called transient relaxation of the lower esophageal sphincter. That means that the lower esophageal sphincter just spontaneously relaxes and causes flux of. And hiatal hernia is what I was kind of alluding to when I told you about the diaphragm. So what a hiatal hernia is that, so remember, this is the esophagus, this is the diaphragm, but what happens with a hiatal hernia is that defect in the diaphragm becomes a little bit wider, either because of surgery or because person's anatomy, obesity could contribute to that, possibly because the intra-abdominal pressure is so high. But a little bit of the stomach pops up into the chest, and that creates lower pressure, that higher pressure here, lower pressure at the lower esophageal sphincter. So the mechanics are such that it predisposes to reflux. And in terms of the clinical spectrum, some people have what we typically think of heartburn, like heartburn and regurgitation. Other people have no real GI symptoms, and cough might be their only symptom. And we're going to talk a little bit more about the complications of acid reflux. So these are some of the consequences. So remember when I showed you before that there wasn't really any inflammation here, and this esophagitis just means inflammation in the esophagus, and you could see more pronouncedly here the difference between the esophagus and the stomach, but there's grades of esophagitis. So in this case, you only see a few small segments, like this is really the only one that I see, and maybe this over here, but it could also involve the entire esophagus, as you can see here, the entire circumference. So these are grade A, B, C, D. What else could happen? So acid refluxing into the stomach, into the esophagus, causing injury, could create scar tissue. That creates a blockage. And this is what it would look like on a barium esophagram. This is what it would look like endoscopically, so it just looks very narrowed. And some of these patients that come in with these food impactions that we have to remove, it's because of a problem like this. What else could happen? So repeated injury over time could cause the lining of the esophagus to change to look more like the stomach. And it might be like a response to the recurrent injury. And the consequence of that is that people who develop this is called Barrett's esophagus, that comes with an increased risk of esophageal cancer. And these individuals have to get screened on a regular basis. Depending on how much of the segment is involved, it could be 2 years, it could be every 3 years. And some individuals are really bad every year. And if we find signs that it may be progressing to cancer, then there's treatments that one can use. And this basically tells you a little bit more of what we have talked about. Oops. So now we're going to talk about dysphagia. So when we think about dysphagia, difficulty swallowing, two big categories. Oropharyngeal, which is a problem with the neck, with the pharynx. Esophageal, which is more of a GI problem. So oropharyngeal is the classic symptoms are food gets stuck up here. Patients feel like it goes down the wrong way. There's coughing, there might be change in the voice, and you have a sense of there could be some drooling and also choking with eating. That could happen if somebody has had a stroke and it affects the nerves, or if they've had some trauma to the muscles up here. Esophageal dysphagia is more problem with the esophagus itself. The sensation is more food getting stuck. And in an extreme case, If somebody comes in with like a piece of steak lodged in their throat, then yes, saliva, all sorts of things will pool, and it could come back, and so drooling may be a component too. So why do people get dysphagia? Peptic stricture is what I showed you, scar tissue at the bottom of the esophagus, so that's a mechanical problem. Sometimes people develop extra lining, which we call a web or a ring. We don't know why this happens, but some people do. A mass could cause a blockage. Esophagitis, and eosinophilic esophagitis is basically inflammation that could cause the disrupted peristalsis, so then food cannot get down. But there's also organs, so the esophagus is not the only thing that's in the abdominal, in the thorax. If there's problems outside that cause compression, so if the osteophytes in the spine are too big, it could cause compression. If you have a mass outside of the esophagus, it could cause compression as well. But we're going to just focus on the GI causes. Okay, so one of the most common, I mean, it's not incredibly common, but we see it a lot, because we get a lot of referrals for it, for people who develop difficulty swallowing without having any mechanical obstruction, is something called achalasia. And this is a problem of peristalsis. So normally, you have a pretty uniform esophagus that connects to the stomach. And if you remember peristalsis, you need the forces that contract and the forces that relax. Problem with achalasia is that those nerves that mediate relaxation die off. Nobody knows why. There's a lot of speculation that it may be an autoimmune process. But what you have is that because you don't have that relaxation force, then you have no peristalsis, and that lower esophageal sphincter doesn't relax. So what you get is a huge esophagus, dilates, and food cannot go into the esophagus, into the stomach. So again, failure of peristalsis and lower esophageal sphincter pressure is high. Sorry?
Would you mind just elaborating on this possible autoimmune?
Yeah, sure. So the theory is, and this goes for other GI diseases as well, is that say you are infected with a possible virus, and your body's your body's immune system is trying to protect you from it, and in the process, some antibodies are made that then look very similar to proteins on the nerves, and that this could be some antibody-mediated injury to the nerves that causes. And this is based on the fact that people sometimes develop achalasia after some illness, but also people could develop achalasia from malignancies, like more of what we call paraneoplastic, where certain antibodies, paraneoplastic antibodies, destroy the neurons. Again, none of this is proven, but this is the speculation. So this is, you remember that that normal esophagram that I showed you? Looks very different. This is a very dilated esophagus, and it has a this is what we call a bird's beak. So when we see something like this, it could be a stricture, but usually we've already done an endoscopy in these patients, and there is no stricture. And so what we see is that bird's beak at the lower esophageal sphincter, no relaxation of the lower esophageal sphincter, dilated esophagus, and the reason they call it sigmoid esophagus is that sometimes it looks just like the colon does. And yeah, so if I showed you a picture of the sigmoid colon, it would look just like this. And that's not normal. And remember how I told you, so remember, normal, you have the upper esophageal sphincter, lower esophageal sphincter, you have nice peristalsis, that's like that diagonal. So with achalasia, you don't get any normal peristalsis. There's 3 different types. There's the one that there's no peristalsis at all, and there's no relaxation of the LES. In none of the cases is there a relaxation of the lower esophageal sphincter. Type 2 is pressurized esophagus, so this is more like the esophagus is behaving like a lead pipe. In type 3, which is the hardest one to treat, is that the esophageal body is just spasming very robustly, so it could cause a lot of chest pain. Okay, eosinophilic esophagitis is an allergic disorder of the esophagus, and what you have is that there's eosinophils in the lining of the esophagus. And eosinophils are allergic type cells. They're white blood cells, and what they are is like little bags of toxic components. And they were discovered in the late 1800s, and we're still trying to figure out exactly what they do. But basically, they're thought to protect us from parasites. So the idea is, like, if you have a huge parasite, it bursts all of its contents into the parasite and dissolves some of the protein. But they're also involved in allergy, and they get activated or degranulated when they come in contact with certain allergens if you're allergic to it. So for instance, if you have a peanut allergy, then your eosinophils will have receptors for peanuts, and when it binds peanuts, they get activated and they release all of this. And that's why people will get swelling of the mucous membranes, because it's really all these vasoactive toxic substances that are being released. So in the esophagus, when you have infiltration of the lining of the esophagus with eosinophils, the inflammation can cause changes in the lining. It could cause scar tissue as well. And this is kind of what it looks like. This is somebody who, so the classic presentation of this is usually a young male who comes in with food stuck. And usually it's a piece of protein, like this looks like chicken. And we have to take it out. And if you see these rings, if you remember the normal esophagus that I showed you, it was very smooth, and you can see the blood vessels. This, you see rings. And you also see some linear furrows. And also the esophagus over time just gets narrower and narrower and narrower. Unfortunately, we don't have great therapies for this. I mean, avoiding the allergens, whenever we can identify it, can be helpful. And there's something called the 6-food elimination diet, where you omit the 6 more common allergens. So that's soy, wheat, dairy, milk, eggs, and shellfish. And then slowly reintroduce and see if the symptoms are better. And topical steroids. So some people call this the asthma of the esophagus. So we use the same stuff for asthma, but we have the patient swallow it instead. And it is challenging to treat, because sometimes patients have no symptoms at all until they come in with that food impaction. So depending on whether they have scar tissue or not, some people have to stay on the steroids indefinitely. Okay, so any questions about the esophagus? Or any diseases that I didn't talk about that you were wondering? Manometry.
Oh, yes. Where does that word come from?
Mano, it stands basically for pressure. So it's measurement of pressure.
Okay, because I thought pressure was
like sphygmomanometer. You know the.
Okay, I thought there was a different word for pressure, like Latin.
Yeah, so manoreceptors in our intestines are basically what detect pressure, so that's where the word comes from.
Okay.
What was that?
Well, that's the.
I was just saying that has to do with the measurement of pressure specifically, as opposed to, it's not the word in that sense, it's the total pressure.
Well,
Oh.
the metry is the measurement.
Yeah.
Cool, thank you.
Okay, no problem. Yeah?
I guess given time and treatment, can it be repaired? The lower scale strength? That the tissues, so you're saying it's kind of like our skin.
Uh-huh.
So if I get a cut, it repairs over time,
Yep.
plus even a scar.
So the GI tract is incredibly great at repairing itself. It replenishes every 3 to 4 days. So, but those are good questions. So for esophagitis, the inflammation, if it's due to reflux, we treat the reflux. And how do we treat the reflux? We treat with medications that block the acid. Those are what are called proton pump inhibitors, and we'll talk a little bit more about it in this context of the esophagus. But also there's surgical ways that you could treat it. And usually if you treat the reflux, then that heals. However, eosinophilic esophagitis, so you have to treat the underlying cause. Eosinophilic esophagitis, we either find what's causing this reaction, what allergen, or we treat with steroids to treat the inflammation. Achalasia, the only way to treat it is to disrupt the lower esophageal sphincter. The way they used to do it is to take a big balloon and rupture it. However, this also caused a lot of perforation, which people didn't do well. And some people still do it. But now we have surgeons basically, I'm sorry?
Do they have stents in that area?
If they were a stricture, a stent would make sense, but this isn't a stricture. So the stents you want to avoid at all costs because they can migrate to bad places. So we only really use stents if there's like esophageal cancer. It's a palliative thing. But with the achalasia, what we do is sometimes we inject Botox if it's an old person that is not a good surgical candidate, and that physically makes that muscle relax, so it keeps it open. So again, when treating achalasia, we don't have a way of restoring peristalsis. The best that we can do is keep the hose open and help gravity and have the patient use gravity to help them eat. So surgeons usually have to disrupt those muscle fibers to keep that open. So I don't know if that answers the question, but that was long-winded. Okay, the stomach. So the stomach, food comes into the esophagus. Here's the diaphragm. Now we're in the abdominal cavity. And the stomach is kind of bean shaped. It has folds that are called rugae. And this is just to remind me to tell you that there's a lot of different cell types that have different functions. There's cells that make mucus. There's cells that create the barrier to prevent things from getting through. Parietal cells make acid. Chief cells make enzymes that break down protein. And neuroendocrine cells make some hormones and other substances that will then activate or suppress these cells. And when we talk about anatomy of the stomach, there's really three major parts. The fundus, which is the tent here, the body, and the antrum. And in the antrum you have what's called the pylorus, which is a very strong muscular sphincter. It's the sphincter of the stomach. The other parts here, so here's the lower esophageal sphincter. The cardia, we call it the cardia is because whenever we're doing an endoscopy, the heart is right behind it, so you can see it pulsating. So this is what the stomach looks like. This is the pylorus. So you see how this stands out as a little bit more muscular. And again, the lining here is more glandular. So this corresponds to the antrum, this area right here. And this opening is the pylorus. And the body just has these very strong folds. And this, what we do is like we have the scope kind of hairpin on itself. So we're looking, you're seeing the scope coming in through the lower esophageal sphincter, and we're looking up at it. So this is the fundus, this tent right here. And when we talk about the stomach, it aids in digestion and secretion, and motility is incredibly important. So digestion begins in the mouth. We have some amylases that break down carbohydrates slightly, so that whole process starts there. It continues in the stomach where there's a little bit more breakdown of protein, but the bulk of the digestion really occurs in the small intestine. So the acid here has an important part in breaking down certain proteins and starting digestion, and also activating other enzymes that will then aid in digestion. So the different parts of the stomach have different functions. The fundus is normally collapsed, but when you have all of this digestion going on, it relaxes to create more room. The body is where most of the cells that make acid are. And the antrum is very muscular, and that's what does most of the grinding. and the pylorus, which regulates how fast things get out of the intestines. So this is complicated, but again, several different stimuli stimulate acid secretion. Vagus nerves is basically from the brain. Food itself in the stomach could cause activation of certain cells that release certain hormones that will then activate the cells and make them make hydrochloric acid. And these parietal cells actually have what are called proton pumps, little pumps that just make HCl. And the medications, like you guys have heard of Prilosec, that's it's over the counter and it's very widely used to treat reflux. What it does is that it destroys the proton pumps in these cells. But the body replenishes it every 3 days or so it's not a problem. And then motility, how do we get things from the esophagus? First of all, the whole digestion. So things are semi-solid in the stomach. Do you guys know how little things the food has to be before it could go through the pylorus? How? Yeah, even less, 1 to 2 millimeters. So it has to really grind it up. In the stomach is what? So again, the fundus relaxes to accommodate the meal. So when there's a problem there, we call it impaired accommodation. And that's what we call dumping syndrome, where things get pushed too quickly out of the stomach. The antrum is what grinds the food, and the pylorus also contracts and relaxes intermittently. And there's feedbacks. So nutrients in the small intestine will then go and tell the pylorus to kind of slow down a little bit and causes the fundus to relax, whereas also tells affects what the antrum does. So it's all coordinated, and this requires the enteric nervous system coordination. Oh yeah, look, I asked you, but here it is. So, and I'm going to show you pretty soon. Yeah, so all of this coordination is also driven by these special cells. They're nerve derived. They're called interstitial cells of Cajal. And this again is all this. I didn't find like a cartoon, a video, but basically there's just a lot of churning going on. And solids and liquids empty differently. So solids doesn't empty immediately. It takes a while. There's a lag. And then when it's all crushed, it goes through. Liquids doesn't require to be crushed, so it goes right through. So when we're talking about pathophysiology, I thought, yes? Huh?
I just stand here.
Okay. Okay.
I feel like this is a really silly question, but so if you're eating a liquid meal
Uh-huh.
through faster,
Yeah.
does it pull out less nutrients?
It should not. If it's because at the end of it all, what we want is for it to be liquid. So it shouldn't. No. No. Yeah.
Keep hearing about all these juice cleanses, and it
Yeah.
seems a little like people who only eat liquid diets now.
Yeah. You're also probably getting rid of fiber and stuff, so it probably people may feel better, but I'm not sure that it really correlates with nutrition. Probably not. Okay, so I know that we have a lot to go through, so let me go through it quickly. Peptic ulcer disease is just that, ulcers in the stomach. And this is a consult that we do a lot when patients come in vomiting blood. And it could be spurting blood like this. It could be more of a crater. Sometimes we see a big old clot, or sometimes we see just like this is a healing ulcer. This is what we call clean-based. And depending on what we find, and we have little clips that we could kind of put over a blood vessel that we think is going to. So this here looks like what we call a visible vessel. So the likelihood of this bleeding is huge. So we would definitely put a clip over it. But the likelihood of this bleeding is nil. So we would just leave this alone because we could do more harm than good. And what causes ulcers? So why am I showing you pictures of a bacteria? So somebody got the Nobel Prize for figuring out that bacteria causes ulcers. And this guy, everyone thought he was nuts. It's like Barry Marshall. So he actually ate bread infected with H. pylori and proved that he got ulcers. He deserves a Nobel Prize. But basically, this bacteria has little flagella, so it can propel itself. But what it can do is it neutralizes acid, and it has proteases that could break down the lining of the stomach. So it embeds itself very deep in the crypts of the stomach, so it's very difficult to get rid of. And this, so it can cause ulcers. And this, in combination with anti-inflammatory medications like Aleve, Advil, really increases the risk for ulcers. But also, having an infection with this over a long period of time predisposes to gastric cancer. So the thing to understand, though, about 2/3 of the world population are infected with this, and only a small percentage go on to develop malignancy. In the United States, we screen for it, and whenever we see it, we treat it, because treatment, it might be an unpleasant 2 weeks because they're intense antibiotics, but then it addresses this issue of possible malignancy down the line. And we are more, so there's standard criteria for checking for H. pylori, but also it gets checked for a lot of other reasons. And this is, so H. pylori accounts for, so you could have ulcers in the small intestine, in the duodenum, or in the stomach related to H. pylori. But also these anti-inflammatory medications on their own right can create ulcers because it breaks down the barrier, the protective barrier. And if you have both H. pylori and use of anti-inflammatory medications, the increased risk is very high. And then there's other etiologies, which this would be acid overproduction, and sometimes critically ill patient and have decreased blood flow, or high dose steroids could predispose as well. So there could be delays in gastric emptying, and this is because of something called gastroparesis, but also there could be rapid gastric emptying, which is what we call dumping syndrome. Gastroparesis accounts for a lot of hospitalizations. Basically, things sit in the stomach, and we don't understand exactly why this happens, but basically it's a discoordination of the nervous system, so there aren't any ordered contractions. The antrum doesn't grind. The fundus doesn't relax. So people feel just really crummy. And there's it's been tied to a lot of things, but the reason for this slide is to show you that most of the cases are idiopathic, meaning we don't understand why. And the symptoms are very varied. Some people feel early satiety, which means they feel full after one bite. But most common symptoms are nausea and vomiting. Impaired fundic relaxation, like I showed before, that impaired accommodation could worsen the early satiety. But interestingly, sometimes one of the first things that you see before the actual onset of the gastroparesis is rapid gastric emptying and dumping syndrome, which means patients eat and then they feel really horrible because you have essentially, so when the food empties the stomach, the acid gets neutralized in the small intestine. But this takes time. And if you dump contents prematurely, then that acid in the small intestine could cause a lot of symptoms. And how do we manage it? Unfortunately, no cure. So we try medications to stimulate motility. That's what prokinetics means. But there aren't any really good ones, and the ones that we have available have really bad side effects. Antiemetics is to treat the nausea, so we do symptomatic control. And then sometimes we try to treat the sensation, because part of the theory is that the nerves in the stomach are also more sensitive, and normal stimuli could cause a much more robust effect. But sometimes we try to treat the pylorus with Botox to keep it open. the outlet. There is something that's called the gastric stimulator that you know all about. It's not a pacemaker. People call it the pacemaker, but it's not. It just delivers electric shocks to the stomach, but it doesn't really improve the gastric emptying, but it does seem to help certain people with nausea. In surgery, in extreme cases, you take out the stomach, but obviously that's very drastic. And sometimes people who have this motility of the stomach also have it in the entire GI tract. So it's a problem.
Really quick, so if the stomach gets taken out,
Mhm.
so IV nutrition? Or
No. So what the
I mean,
small,
I know food a lot, that's why I'm asking.
you would think so. So the stomach is not a viable iris. This is actually a good segue. So you don't of all the GI tract, the only thing that's essential is the small intestine. So you can live without the stomach, you can live without the esophagus, you can live without the colon, but you cannot live without your small intestine. So it may change things a little bit, like you won't be able to eat as much in one sitting, but people do fine, and nutrition is not. And there, obviously, every surgery there's complications, so people could develop strictures. And so one of what we employ as a first line for gastroparesis is dietary therapies. So we tell them to eat smaller meals, so no more 3 meals a day, and low fat, low fiber, because those are the things that really hang out in the stomach. We could still supplement fat and fiber liquid, but we try to not to mix it, because high calories is one of the things that further tells the body slow down gastric emptying. So we try diet first, and then we do symptomatic control. Yeah.
Still, I mean, like for these patients, do you still prescribe the COX-2 inhibitors, or you would kind of?
COX-2 inhibitors, we gastroenterologists don't like any kinds of NSAIDs, to be honest, but the reality is that if there's a clear requirement, we do our best to protect them. So whenever somebody's going to be on either COX-2 inhibitor or NSAIDs, then we wind up putting them also on a proton pump inhibitor to try to protect them and making sure that they don't have H. pylori. Okay, so we're talking about the GI tract. I'm going to just briefly tell you a little bit about the pancreas and the liver, because they also aid in digestion, and they're important. So the liver detoxifies. It sits in the right upper quadrant, and it makes bile. So the gallbladder is essentially like a little purse for bile. And the bile you get on demand if you eat something fatty, and because it emulsifies the fat, sort of like the egg and mayonnaise. I've been told. And then there's a little duct that courses through the head of the pancreas and empties into the small intestine, the duodenum. So to orient you, this would be where the stomach is. This is the pylorus. It empties into the first part of the small intestine that's called the duodenum. And the pancreas sits way behind the duodenum. And that's one of the reasons why pancreatic cancer is so difficult to detect, because it's so deep embedded that you don't really have symptoms until it's really game over. So the pancreas makes a lot of important enzymes to break down fat, so amylase, lipase, carbohydrates, and fat. And when there's food that enters the small intestine, the pancreas releases these pancreatic juices, and the gallbladder contracts and releases bile. So that's really the bulk of the digestion where it occurs. Okay, so they're both very important organs, but they're outside of the GI tract, but they are connected. Now let's talk about the small intestine, which is my favorite organ. And the small intestine, remarkably, is 22 to 23 feet long. And if you remember from high school biology, if you stretch it out, it's as big as 2 tennis courts. And this is where we absorb most of our nutrients. So stomach, pylorus, duodenum, then you have the small intestine kind of neatly folded in the middle, and you have has it connects to the colon in the right lower quadrant, and then the colon sort of is the borders. The small intestine is divided into 3 sections. The duodenum, which is the first part. The jejunum, which is, so the duodenum is the first 4 feet. The jejunum is going to be like the next 8 feet. And the ileum, oh, they kind of misspelled ileum. I didn't notice that. It's ileum. It accounts for the last like 12 to 16 feet. And in the digestion, absorption, immunity, and motility are the big functions of the small intestine. So first, digestion. So the small intestine is, the lining is coated with an epithelial cell layer, and beneath it are immune cells, and there's also capillaries. So carbohydrates get broken down. There's enzymes on the brush border. So you guys have heard of lactose intolerance. We're going to talk a little bit about that, but that's because people lack the enzyme that breaks down carbohydrates. And then, so all of these things get broken down by the pancreatic enzymes, by the enzymes present inside the lumen meaning the inside of the intestine, to small enough fragments that then they could be absorbed. And different things are absorbed in different parts of the small intestine. So these nutrients are absorbed mainly in the duodenum. The jejunum is where most things are absorbed. But then there's certain things that are taken up just at the end of the small intestine, in the ileum. And this slide just says that, so again, this is the workhorse of our GI tract. And the lining is organized in villi. So these are finger-like projections, and this basically increases the surface area. That's why, if you stretch it out, it's as big as 2 tennis courts. And each of these little finger-like projections, this is like a magnification of that. At the core, you have vessels and lymphatics, and this is where absorption occurs. And again, this is our biggest immune organ, and the GI tract has this immense monumental task. So you have a single epithelial cell layer separating you from the biggest immune organ. And if you think about it, all sorts of things come into contact with our GI tract. There's food that we eat that shouldn't elicit an immune response. There's pathogens, there's good bacteria, there's bad bacteria. And our immune system has to discern friend from foe and constantly be protecting us. So I'm not going to go through the details of this, but it's an extremely complicated process. So when we talk about intestinal pathophysiology, we talk about malabsorption, meaning something's wrong with the GI tract, so you cannot absorb nutrients. And the big categories are going to be enzyme deficiencies, either pancreas. So if the pancreas doesn't give you those juices to break down stuff, that could cause malabsorption. Mucosal disease, so the lining of the intestines could get destroyed, and we're going to talk about an example, celiac disease. But if you've had surgery and you have parts of your small intestine missing, that's going to cause a problem. Certain infections, there are some diseases that affect the GI tract, like lymphoma, amyloidosis, that causes infiltration of the lining and interfere with absorption. So a little bit on lactose intolerance. Or in general, carbohydrates. So carbohydrates are broken down to disaccharides, 2 molecules. And in order for it to be absorbed, it has to be single molecules. And when, so glucose and fructose is what makes sucrose. So that's table sugar. So that gets broken down into glucose and fructose. And that is absorbed by certain processes in the cells. But if you're lacking the enzymes that break it down from the 2 to 1, then you won't absorb this. And lactose is made of glucose and galactose, and a lot of people lack this lactase enzyme. So But if you're not able to break down lactose into its components, then what happens is that it goes untouched through the small intestine, and then it hits the colon where it gets fermented by bacteria. So it could cause a lot of gas and bloating, and that distress that we know. What's interesting about lactose intolerance is that we always thought that if you can't digest lactose, then you're abnormal, you're the mutant, but it's the other way around. So normally what should happen is that very early in development in the fetus, the expression of lactase is really high. Well, in the infant, presumably because we rely on milk early on. But as you get older, you're supposed to not, it's supposed to shut down. But what happened in evolution is that some populations kept the ability to digest lactose. And this is called lactase persistence. So that really is supposed to be the abnormal scenario. So there are like certain parts of Egypt and Caucasians, like African Americans and Hispanics, the likelihood of developing lactose intolerance in their life is almost 100%. So it's something, it's not life-threatening, it's not dangerous, it's just kind of difficult to deal with. But there are strategies that we use. Okay, now my favorite disease, which is celiac disease, is basically intestinal damage caused by gluten. And you guys, I'm sure, have heard of gluten because it's all over the place. So the problem with celiac disease is that for some reason, glucose is activating the immune response, gluten is activating the immune response when it really shouldn't. So when we're born, we're exposed to all sorts of things, good things, bad things. And there's specialized cells in our body that go to the surfaces where we may encounter pathogens and basically tell immune system, okay, if it's blueberries or something that you need to survive, don't react when you see this. If it's infection like salmonella, then you want your immune system to react. So in celiac disease, what's happening is, for some reason, an otherwise innocuous protein like gluten is being recognized by the immune system as a potential pathogen. So you can imagine if you eat bread and it's lining your small intestine, then your body thinks it's an invading pathogen. That's where the immune response is going to be triggered. So when we talk about tolerance, it means normally gluten should not cause the immune cells to activate. But in celiac disease, what we have is activation, inappropriate activation of the immune response that results in destruction of the lining. And this is what gluten is. It's just basically a protein. It's found in wheat, barley, and rye. And in patients with celiac disease, it's toxic. And what happens is over time, so this is the epithelial cells, and every time that the body is exposed to gluten, it activates this immune response, and over time, those nice little finger-like projections that I show you get destroyed. And the consequence of that is that's where you absorb nutrients, so you'll have malabsorption. So the small intestine normally looks like a nice hollow tube. The lining, you will notice, is different from the stomach. This has those nice little sea anemone looking finger-like projections. In celiac disease, you could see that that's gone. And what you have is gaps. You also have nodules, and everything looks a little bit more shiny, whereas in the normal situation, it looks more velvety, like a velvet rug. It could present many different ways. Some patients have no symptoms at all. Some patients have symptoms that are typical of irritable bowel syndrome because they've had abdominal pain and diarrhea and such. So sometimes there could be a long delay in making the diagnosis. And we detect it by picking up some antibodies. So if you remember, one of the things that happens when you get an infection is that the body then makes antibodies. So if you see it again, it'll be ready. In celiac disease, there are antibodies against gluten, and this is what these gliadin antibodies are, but also against this protein called tissue transglutaminase, which in celiac disease actually is what makes modifies gluten to make it more attractive to the immune cells. So these antibodies in celiac disease don't protect you, but they serve as markers for disease activity. So we use it as a diagnostic test. And they're very sensitive and very effective. And we also go into the small intestine and we take little snippets so we can look at it under the microscope and see how much degree of injury there is. And visually also we can tell what it looks like. And the treatment is taking out gluten. It's the only known therapy, the only effective therapy, although there are some treatments in the horizon. So small intestinal bacterial overgrowth, and I'll go through the rest very quickly. So we have billions of bacteria that live in the colon, and they need to be there. They're important for health and disease. And the small intestine has very few bacterial numbers. However, there are situations where these bacteria that live in the colon are given an opportunity to set up shop in the small intestine. And it's not that they're pathogenic, it's more of a matter of being in the wrong place at the wrong time. So if they're in the small intestine, they're going to interfere with, they could break down bile salts, so it could affect the way you digest acids, fats. Also, they could ferment stuff, so it could cause gas and bloating. If a patient has altered anatomy or they have inflammation in the small intestine, or if they have a disease that make the motility of the small intestine be very slow, then that predisposes to small intestinal bacterial overgrowth, and we treat it with antibiotics. So stasis is what causes the bacteria to set up shop in the small intestine. Short bowel syndrome. Basically, again, you can't live without your short bowel. If you have less than 20 centimeters, depending on what's missed, and this could be gunshot wounds, patients who have like certain inflammatory bowel diseases where you have to have parts of your small intestine removed, or if there's an obstruction or peritonitis that causes problems and a large chunk of the small intestine has been removed, then these individuals, if they have less than 200 centimeters, which is probably, I don't know, 3 to 4 feet, you guys could do the math. I can't do arithmetic anymore. Then there will be profound deficiencies in certain nutrients, and in an extreme case, they may have to be fed through the veins. Stanford is pioneering, there are small bowel transplants, and we're going to start one soon, but these patients so far they don't do great, because think about it, the immune system, our biggest immune organ is in the small intestine, so there's a lot of rejection, and it's very, very difficult. Okay, so home stretch, colon and rectum. So the colon, you have the appendix, which is a vestigial organ that kind of attaches to the colon. It doesn't really do anything except when it's a problem, when it gets inflamed and it proliferates. What attaches to, so this is the ileum, that's last part of the small intestine, and that attaches to the colon. So we're talking about the right side here. So this is in the right lower quadrant is where the small intestine and the colon connect. Then it comes up, that's why we call it the ascending colon, and that's this right here. And then it goes across, that's why we call it the transverse colon, and then it goes down on the left side, descending colon. And inside, this is what it looks like. So you see this fish mouth here? This is the opening to the ileocecal valve. And if you go through there, you'll be in the small intestine. This little indentation is the appendiceal orifice. So if I were to go right through there, that's where the appendix would be on the other side. This is a very normal colon, and you see nice blood vessels. This is the transverse colon and the rectum. Again, it's that having the scope kind of loop on itself, so I could see this is the scope going through the anus. Okay, so the colon function really delayed passage of luminal contents. It facilitates absorption of, so digestion requires a lot of water, liters. 12 liters or so enter the colon per day, and the colon absorbs it so that you have about 300 feces or less. So there's storage, mixing of feces, there's a lot of bacterial fermentation, and the microbiome is the new hot thing because it seems like bacterial genes outnumber human genes like 10 to 1, and they're equally as important in health as in disease. So it's really exciting as we learn more about it. And also, motility is important here. So we can't talk about colon pathophysiology without talking about inflammatory bowel disease. So inflammatory bowel disease is thought to be more of an autoimmune disease in the sense that it's the body attacking itself. Celiac disease, the body attacks itself because of gluten. So the trigger in inflammatory bowel disease is thought to be that for some reason we're mounting an immune response to the bacteria that normally live in our colon where we shouldn't. And it comes in two flavors, Crohn's disease and ulcerative colitis. Ulcerative colitis is a more superficial inflammation, but it always involves the rectum and it goes up. It could involve just the rectum, it could involve the left colon, it could involve the entire colon, but it doesn't involve the small intestine. Crohn's, on the other hand, usually doesn't involve the rectum, but it can. But it has what we call a more deeper inflammation. So the inflammation could actually span all the layers of the colon and it could fuse into nearby organs. So patients with Crohn's disease could actually form a communication between the bowel and the skin and have bowel contact build into the skin, or they could form communication between the vagina and the bladder and the bowel. So it's a really, really difficult disease to treat, and it could skip lesions, so meaning this area is inflamed and then normal, and then a few centimeters down the line, inflammation. It could affect any part of the GI tract from the mouth to the anus. And thankfully we have more therapies now, but it's still a challenging thing. So differences between ulcerative colitis and Crohn's distribution. Again, ulcerative colitis always involves the rectum and goes up. So both could have ulcerations, but with Crohn's disease you get more of cobblestoning, and I'm going to show you some of this. With Crohn's disease you also get strictures, scar tissue, so blockages are possible. This is Crohn's disease. So this is a lot of inflammation. This is a far cry from that normal colon that I showed you. And this is the terminal ileum, so you lose the villi, and all could scar down to cause blockages. And what this is what's called a granuloma, which is a histologic finding that you see under the microscope. It's not present in all of Crohn's, but if you see it, then it's pretty likely that it is Crohn's disease. This granuloma. I'm sorry.
What are the hallmarks? Sorry, I'm not familiar.
Oh, sorry. Go ahead.
What are the hallmarks? I mean, what exactly are you looking at that makes it different?
What looks okay? So, yeah. So what you're seeing here is. So let's go back to what the colon normally looks like.
Are you just talking about the histology of it?
Oh, the
So just
histology.
the
Sorry. Yeah. Sorry.
I'm just not familiar with looking at the histology.
Yeah. So these are, yeah. So these here are colonic cells, and these are inflammatory cells. So these guys here should be there. You see the ones with the very dark round nuclei? What I was talking about is this. So it's, the nuclei are different, and it's just like a combination or a conglomerate of macrophages that are condensed there. And it's what's called a granuloma. So if we find it and we're suspecting Crohn's disease, we're happy because we know that's a diagnosis. But it's not present in all the cases of Crohn's disease. And ulcerative colitis, basically here you see more superficial inflammation. It rarely causes stricturing, and patients with this tend to get a lot of really intense pain and bleeding. The thing about ulcerative colitis is if you're sure there's ulcerative colitis, if you remove the colon, it's considered a cure. But the problem is that there are a lot of cases that are indeterminate, so you can't really tell whether it's Crohn's disease, whether it's Crohn's disease masquerading as ulcerative colitis, and so some cases aren't clear cut.
Are there other types of colitis besides ulcerative, or is that?
So ulcerative colitis, sometimes you hear it called as proctitis if it affects only the rectum, left-sided colitis if it affects only the left, and universal is the entire colon. Crohn's disease could come in several varieties. We call it ileitis, or if it's just involving the terminal ileum, because that's the place where most happens. But there's also Crohn's colitis. We also describe Crohn's as penetrating when it causes those fistulas or communications between adjacent organs. And also some people develop really horrible perirectal, perianal abscesses because of these abnormal communications. So usually. There is something called microscopic colitis that we see in celiac disease, where if I go in, everything looks normal, but if you look at the biopsy under the microscope, there's some low-grade inflammation. But usually when someone says, I have colitis, this is what they mean. There's also infectious colitis, which C. difficile is the most common. And this is an antibiotic-associated infection. So you have good bacteria, you have bad bacteria. You take an antibiotic, you kill off indiscriminately good and bad bacteria. So in C. difficile occurs in patients that are chronically in and out of the hospital. So they've acquired some bad bacteria, and then we knock out the good stuff, and this populates. And histology, this I know better to describe, but these are the colon crypts, and what you see is, so these are what are called goblet cells. They make a lot of mucus. And what you see classically, it looks like a volcano eruption. And when you look at it in the colonoscopy, it's just coated with this yellow exudate that washes off pretty easily. It could be really awful and causes megacolon, and people could die from this. This is why we do stool transplants now. We treat with antibiotics, metronidazole and vancomycin, and that's still the first line, but people who fail, the FDA has approved a fecal transplant for it. I did my first one about 2 weeks ago. Irritable bowel syndrome, you guys have probably all heard about. So it's recurrent abdominal pain or discomfort associated with altered bowel habits. And the story with irritable bowel syndrome is we've looked. Everything's normal, so we don't have a specific disease process, and there's specific criteria that are used to diagnose irritable bowel. There's several different subtypes: constipation, diarrhea, mixed, where they alternate with diarrhea and constipation. And I'm not quite sure what unsubtype means. I think it's where you really suspect irritable bowel syndrome, but they don't really fit into a one neat category. Have you guys ever seen that? So we rate stool, and this is actually a really useful tool because what we consider normal is 3 to 4. But if patients are having trouble with evacuation, and it really helps to understand what's happening. What are some causes? We don't really know is the bottom line, but there's a lot of speculation. There could be some altered motility. Visceral hypersensitivity is that process where the nervous system of the intestine just becomes a little bit more sensitized. So normal stimulus will cause a much more robust sensory response. There's areas in the brain that are thought to contributing. There might be inflammation, but the inflammation may be at the level of the nerves, and we can't really access that, so we can't really detect it. Also, there could be a genetic component, and if we alter the bacterial flora, that could be a contributor as well. And this slide basically says all of that. So they've discovered places in the brain that are more active in patients with irritable bowel syndrome, and now they're also looking at, leaky gut, where more nutrients, more things leak through the small intestine. That could be a contributor. So the bottom line, we don't really know. And this is the kind of thing that different therapies work for different people, probably because we're clumping a lot of different disease subtypes into one big umbrella. And so we are not where we are with IBD. We are with IBS where IBD was like 100 years ago in trying to understand and categorizing it more. So a little bit on constipation. It's a huge problem, and the symptoms could be incomplete evacuation, meaning they feel the urge but they just can't push it out. Hard stools, feeling blockage, sometimes they have to manually disinfect, and in general, less than 3 bowel movements per week. There's several different subtypes. Slow transit, which means just that it's very slow to get through, to get to the rectum. Normal transit could be the situation in irritable bowel syndrome, so that could be a problem with the nervous system discoordination. And then pelvic floor dysfunction, which is called obstructive constipation. And this could happen both with slow transit and normal transit. And I'm going to talk a little bit more about what pelvic floor dysfunction is. So the way we evaluate motility, we have better ways now, but this is the classic way, where you give patients a little pill that has these little metal rings, and then they swallow it. They come back for an X-ray a day and 5 days later. And depending on where they are in the colon, normally they should have already left the body. But if they hang around, then we know that there's a motility problem. Eventually, they will get out. I had a patient recently who had one of these, and she found out she was pregnant a few times, so she thought that these were radioactive. And they're not radioactive, they're radio-opaque, meaning that we can see them, but it's not like they're emanating any radiology or anything. Okay, so pelvic floor dysfunction. Pelvic floor dysfunction, just like swallowing, it's a big affair to have a bowel movement, and it requires input from the brain, and it requires the nervous system of the guts. So normally at rest, in order to maintain continence, we have certain pelvic